3 p.m. Eastern Time. This is Connie Jorstead, the Director of Emerging Infections at ASTHO. I'm on the Infectious Disease and Immunization team here. I'd like to welcome you all to our webinar today called What Does Ebola Have to Do with Flu? Engaging Faith-Based and Community-Based Organizations and Community Outreach During a Public Health Emergency. This is sort of one of our activities that we're doing in conjunction with National Influenza Vaccination Week. So happy that to everybody. I hope you guys are all engaging in some activities to promote influenza vaccinations in your communities. I wanted to just share with you very briefly about this webinar a couple of things. First, we are recording the webinar. So we will have that archived if you want to share that with colleagues in the future. We will be sending a link out to that so that you can access that and share that with others who may or may not have been able to join you today. We will have slides available, obviously, as the archive in the archived version of the webinar. We're going to be trying to get to post that on our website, so the PowerPoint presentations will be available for access later. And if you have questions as presenters are speaking, I welcome you to use the chat function on the webinar portal so that we can keep track of those and ask those during the discussion period at the end of the webinar. So just a little bit So again, my name is Connie Jorstead. I'm here with ASTHO. I have the speakers that have agreed generously to give a little bit of their time and some of their insights about their response to Ebola and helping their communities respond and be prepared for Ebola and better understand what Ebola virus disease is and how it might affect their communities. But more to the point of today's conversation is, what have we learned from Ebola that might help us better prepare for other infectious disease threats? For example, pandemic influenza, but especially as we enter into flu season, what does that have to do with seasonal flu? So just a little bit of background. ASTHO, with the support from CDC, provides capacity building assistance to state health agencies to increase their capacity to plan for and respond to a flu pandemic. We do this work through our preparedness team, as well as our infectious disease and immunization team. Much of the work that I work on in terms of better responding to a flu pandemic involves developing and enhancing community partnerships with a large number of types of community partners, including healthcare providers, pharmacies. We've done some work with workplaces, but again, today's focus is going to be on faith-based organizations and community-based organizations. And I've provided here a link, which you can find on the ASTHO website in the infectious disease pandemic influenza section of our website. It's not advancing. So we have been partnering in particular with the Emory Interfaith Health Program to work with a network of faith-based organizations that they've been working with over time to increase flu vaccinations and prevention messaging in their diverse communities. We developed a toolkit, which you have a picture of here, a thumbnail sketch, which you can also find on our website. And this is to help state health agencies to improve their partnerships with the faith-based organizations in their communities. We're also looking to expand this work to do sort of an ancillary document where we would be aiming more towards the faith-based organizations to help them better understand their public health partners. Finally, much of the focus that we have in this work is really on addressing the needs of at-risk, vulnerable, and minority populations. I'm sure many of you are already very aware of some of the basic rationales for why public health might want to partner with faith-based organizations. Here's three of them. In particular, their pervasive social structure within communities and they have a large sort of reach into communities and can exist in many different ways, be it your traditional faith-based organization in the community, be it like a church, a synagogue, a mosque, also healthcare, faith-based and faith-oriented healthcare systems, so your clinics, hospitals, and things like that. Also faith-based or educational facilities. And as we all know, they hold a kind of trust in communities that oftentimes public health has a more challenging time reaching, and certainly has a harder time engaging in a level of trust relationships that public health sometimes has a challenge with because they represent government. So working with faith-based organizations and community-based organizations can really help enhance the relationship and the reach of public health into those communities. And certainly we see in many faith traditions, there's a value and commitment that aligns very well with and can contribute and enhance public health goals. So I wanted to make you all aware that there is a very brief application process that's currently open to state health agencies in terms of helping you build community capacity to prevent flu through any faith-based collaborations you might have in your jurisdictions. The RFA comes with a small sort of mini grant, if you will. It is a brief application. I believe it's 2 pages or less. And it would support your state health agency, any sort of part of the agency, be it that might be interested in working with faith-based organizations. So this might be, your minority health offices, your influenza work, your immunizations work, preparedness sections might also be interested in this, and it's going to help you in terms of providing some peer mentoring, hopefully help you to build your networks at a more national level, to build some technical assistance opportunities, and it does again include a small sort of mini grant stipend type thing to help support some of those efforts that you might do in your jurisdiction. The application is due on Friday. Again, it's very brief. We wanted to keep it simple and easy to facilitate as much interest as possible. And you can find that on the Emory IHP website, and there's a link in the upper right-hand corner of the website thereabouts to the RFA. So I'd like to introduce Scott Santabanez. He's with the Centers for Disease Control and Prevention, and he has a few remarks to share and some insights and has a lot of background with working with faith-based organizations. And so, Scott, I'll turn it over to you.
Well, thanks, Connie. I'm just going to mention a couple things briefly this afternoon. So the 2 things that I wanted to cover were, first off, how Ebola and influenza are similar and how they're different. And the second thing I wanted to cover was to let folks know about a resource, an article that's going to be coming out soon, and it covers some tips on how public health can work with community organizations and faith-based organizations around health communications. So we'll let you know that resource will be hopefully coming out sometime in the near future. So first off, how are Ebola and influenza similar and different? And I think that most people on this call are going to be pretty familiar with this. So this will just be a quick review, and we just want to make sure that everybody's starting off on the same page here. So when we look at how these viruses are transmitted, as you know, the Ebola virus is not spread through the air. It's spread through contact with bodily fluids. So that would mean a caretaker coming into contact with blood or diarrhea or urine or some body fluid from someone who is a known case of Ebola, and that person might get the fluid in a cut or a crack on their skin and get infected that way. On the other hand, influenza is spread through the air when someone is sick and they cough and sneeze, and so someone close by in the same room could get influenza through the air. Now, the fact that these routes of transmission are different greatly affects the potential for spread. And so with Ebola, we're really looking at a limited, very small number of people who've been affected here in the United States anyway. And it's really unlikely that there would be a widespread outbreak here in the United States. In fact, the cases of Ebola here in the U.S. have been limited to the Liberian gentleman who came to Dallas and tragically passed away from Ebola infection. The two nurses who were infected while providing care for that gentleman, who thankfully have since recovered. And there have been a handful of people who have been infected overseas and came to the U.S. for treatment, but really the numbers are limited to that small group. In contrast, as you know, influenza can be much more widespread. We don't know what this upcoming flu season will look like because they're all different, but typically with influenza, you'll see us put up a map of the United States, for example, and show which states are having widespread transmission, that kind of thing. So it's really a magnitude difference in terms of the numbers affected. In terms of prevention and treatment for these two different viruses, with Ebola, we really think that the best way to prevent new cases here in the U.S. is to kind of put out the fire at its source, so to speak, to address the epidemic that's happening in West Africa. So currently CDC has several hundred staff that are working in West Africa to help stop the outbreak there. Also, there are many volunteers that are working. The military has been a part of that effort, and we're really trying to stop the outbreak there at its source. When someone is infected with Ebola, the treatment is primarily supportive treatment. We're told that people who are infected with Ebola lose tremendous amounts of fluid. So we're really supporting them with intravenous fluids, with oxygen, supporting their blood pressure. Our colleagues at Emory University say that these people can lose 5 to 10 liters of fluid a day, so they really have difficulty holding on to fluids, and we're supporting them through this time while their immune system recovers. Now, I'm sure you've heard about and maybe have been asked questions about the experimental treatments that are out there, things like ZMapp. And so the important thing to remember about these treatments is they are still experimental. We don't really know if they work or if they're safe, and on a case-by-case basis, it may be determined that the benefit of trying an experimental treatment outweighs potential risks, and so it's worth using those experimental treatments. But we don't really have a lot of data about those interventions. In contrast, with influenza, we do have interventions that we've studied for many years. And so we continue to encourage people to get their flu shot. Now, I'm sure you've heard reports about this year's flu shot and how one of the 4 components in the flu shot, because there was a drift in that particular strain, there's only about a 50% match with that particular strain, the H3N2 strain. We still encourage people to get their flu shots because for protection against the other strains, as well as there may be some protection still against H3N2. So it's still good to encourage people to get the flu shot. And the additional message that we want to get out this year is early treatment with antiviral medications like Tamiflu, particularly for people who are in a high-risk category, people with chronic medical conditions like diabetes, the elderly people, children. It's important that they, if they have symptoms of flu and are thought to have influenza, that they get the antiviral treatment early. The last thing that I'll mention about these two viruses is the importance of communications. And so with the Ebola virus, it is important to get communication messages out to our communities. And the communication messages that we want to get out about Ebola are just basic information about how it's spread, what people's risk is, calming people's fears and that type of thing, and addressing and decreasing stigma that we've heard about in our communities, not stigmatizing people who may have connections to or travel to places outside the U.S. With influenza, the communication message is, again, about getting the flu shot, about antiviral treatment for people who are particularly in high-risk categories, and good general hygiene messages, staying at home when you're sick, hand washing, that kind of thing. But so the topic of communications leads me into my second thing that I wanted to mention. And so we have an article that will hopefully be coming out in the near future that I worked on and Connie Jorstad also worked on, and it's to help public health people to be able to work with community organizations and faith-based organizations around health communications, and it particularly focuses on Ebola. And I'll just mention a couple things about it briefly. So one of the things that we recommend in that article is incorporating health communications with community partners, with faith-based groups into an overarching public health emergency response plan. So what we are saying is that partnerships with these community groups should be a part of planning the same way disease surveillance is a part of planning, the same way vaccination is part of planning, and clinical. It should just be a routine part of the emergency preparedness process that health departments go through. Another thing that we cover in the article is how public health can work together with the community groups and faith-based groups to develop messages for communities. And we talk in this article, we specifically mention stigma and messages about decreasing stigma that you can help get out to communities. Avoid making negative comments on social media about groups of people and risk of Ebola, that type of thing. Avoid shunning friends and coworkers who may have recently returned from an area where Ebola is endemic. So hopefully you'll have some useful tips and resources that you can use there. One of the last things we mention in this article is the importance of maintaining relationships with community partners and faith-based groups. And so it's important to maintain these relationships between public health and these groups, even when there isn't an emergency going on, so that when there is an outbreak or there's a health initiative, flu season, that kind of thing, the relationships are there and in place, and there's trust there, and you can work well with these partners. So when that article is released and available, I'm sure that Connie will be able to let you all know about that and make sure that you have a copy of that. So with that, I'll end my time and pass it back to Connie. Thanks.
Thank you, Scott. That was great. So I would like to turn it over to a couple of colleagues from Minnesota, Danushka and Sarah. If you want to go ahead and take over the reins, you are welcome to do so.
Great. Thanks, Connie.
Hi, everyone. This is Sarah Schutt. I am the International Health Coordinator here at the Minnesota Department of Health. Happy to be with you today, along with my colleague Danushka Wandaragala, who is our Limited English Proficient Communications Planner. So we wanted to talk today about some of the best practices that we have in community engagement, a couple of the lessons learned or key takeaways from H1N1, and then Danushka is going to talk more about our specific Ebola response here during the last few months. And then we're going to wrap up with a few strategies that we think are useful to think about. So Minnesota has a rich history of refugee resettlement. For those of you who don't know, we have among the largest populations of Somali and Hmong communities, as well as very sizable Liberian, Ethiopian, Vietnamese, and many, many other communities. And we've been resettling refugees since 1979. In our program specifically, the Refugee and International Health Program, we really focus on health promotion, communications and planning, specifically to reach limited English proficient communities, emerging health issues like Ebola and like H1N1, for two examples, and consultation and training. We are so lucky in Minnesota to have a wealth of bilingual and bicultural organizations and professionals. And so building capacity and credibility externally is really critical, but we are lucky to have a lot of people to help in that process. So some of the examples of ways we have done that in the past and ongoing are our community health education project, which does include a number of faith-based partners or community groups that work very closely with faith-based mosques and temples and churches. An example is the Ethiopian Nursing Parish Group, which is a small nonprofit organization that's located in a church, and they do a number of flu shots every year, as well as health fairs and other health education activities. Then we have the Mini Project. It's a partnership between MDH and several clinics, hospitals, and different organizations, and they work with faith partners as well to provide flu shots in largely a number of faith-based and community-based settings to a diverse range of community partners. And we get some funding supported from the Minnesota Department of Health, but are a wonderful, wonderful resource and model. We have developed a health curriculum on 9 topics to specifically partner with English language learners, so in adult basic education centers, and that curriculum we hope to put on our website very, very soon. And then lastly, building credibility and capacity with our local public health partners. So there's a wonderful model in Hennepin County. They have a cultural service unit where they train and develop community connectors that can go out and disseminate messages on health and safety to their own communities in an appropriate way. One last example before diving into H1N1 is our diverse media projects. And we work with anywhere between 20 and 30 different diverse media outlets per year, focus on a number of different, targeting different populations through radio, through community TV, like Somali TV, through different bilingual, bicultural newspapers, African News Journal, Asian American Press,
Liberian Journal,
et cetera. And Danushka will go into some of the more tailored campaigns we did on Ebola, but we have been doing these campaigns for a number of years and tailoring them linguistically and culturally to make sure, of course, the message matches their population.
And I would add, investing into these, diverse media vendors, we buy the ad, but quite often they are placing our full article on that health topic for free, in addition to that ad we purchase. So, they appreciate supporting their business, but they also want to help get that information out there.
Absolutely. And so specifically talking about H1N1, during 2009, as part of our incident command structure, we were asked to participate in a special population subgroup. And specifically looking at our role was to really help make sure that limited English proficient communities were getting reached. So we provided consultation on how to reach these diverse populations, working with a local nonprofit called ECHO Minnesota to develop messaging in a number of different languages. We did a video on H1N1 in at least 7 languages and public service announcements in at least 11 different languages. And also coordinated different media interviews, again, on diverse bilingual radio, TV, with different newspapers. We conducted different statewide health forums and community forums. We provided health education in English language classes. We trained staff here in the department on how to use our language line to make sure that anybody calling into the department who did not speak English would have a way to get an interpreter right away. And some key takeaways from H1N1 were really needing to assist our community partners and community-based organization in developing their own continuity of operations plans. And it's just essential to keep that list of your community contacts and leadership up to date. And expanded as much as possible, and make sure that you're identifying gaps in communication and adapting your methods for updating community partners and community groups as you go, so that you're checking in continuously to make sure that you're in tune with what the community needs, and are they even, is our message getting out there? Is it reaching people? And last but not least, really partnering with local public health, because we cannot reach everybody statewide alone. We have to do this in conjunction with a number of other partners, and our local public health partners often are a great gateway to doing that, and making sure that we're not duplicating efforts, but rather strengthening and promoting our message in many different ways.
Great. And so focusing now on Ebola, what happened was in mid-July, because of these relationships that were already built up we had a couple key leaders in the West African community reach out to us with concerns about Ebola that was growing in their native countries. So what we did was we responded by meeting with them and continuing to do outreach work, but really engagement work, treating them as a partner and having them consult on a variety of things that I will touch on later. But in August, we continued the work. Things were ramped up when the first U.S. case occurred. And then in October, we started the monitoring program, which is another portion where we continue to have to work with the community to get messaging out. So we brought leaders together from all 3 affected countries at that point in July, making sure to invite Christian and Muslim faith leaders and really bring them together to hear their concerns and questions, but also develop our own frequently asked questions document on Ebola. And then we planned collaborative efforts like community information center sessions, information dissemination plans. And based on that initial meeting, those leaders ended up continuing to meet, and they ended up forming their own group, the Minnesota African Task Force Against Ebola. And this umbrella group really worked to help coordinate all the various nonprofits and community-based organizations that were doing Ebola-related work, but also as a liaison between the community and local public health, the state health department, and other entities as well. And we've been told by numerous leaders that they had never worked together until we brought them together for that initial meeting. We also keep them involved by doing consistent information sharing. We send out 2 to 4 emails per week with those community and faith leaders to share information whenever we change or make additions to our website, when CDC sends out updates, when we stand as one, that the effort through CDC, we connected a lot of the local leaders to that group. And so just continuing to always make sure that they have the most up-to-date information, which they're in turn posting on their social media, they're making announcements at their churches and mosques. And so it's really become a very nice network of information sharing. So we did a series of community info sessions and forums. We'd always make sure to book it out a week and a half ahead of time so that we could get flyers to the churches and mosques so they could disseminate them on days of worship. And these leaders really worked with us on assisting in messaging. So when we were putting out our ads to get more information on Ebola out there, we consulted with them, made sure that the message was clear and what would be most effective. But we've also had to come back to them on a variety of other topics. For example, when we started monitoring, we wanted to make sure that the community saw this as a collaborative effort for a better good. So they really worked with us to help get information out in the community, as well as tell community members who had recently arrived to work with the state health department for those 21 days of monitoring. Let's see. So, and then we also, with regards to media, so they helped with the messaging. And so there's some examples of some of the diverse media that are based in Minnesota, but knowing that some of that messaging is also reaching their relatives and those who utilize these periodicals and media in West Africa. So Pepper Soup is a Liberian health website based here, African News Journal, Liberian Journal, Mshale, so quite a few. And so we ended up making a media kit where we were providing PSAs on Ebola, an article, and an online print ad, which they all gave at a reduced rate and then posted the articles for free. So here's a slide of one of our first sessions, which were really focused on getting information out about Ebola. Those first couple months, July, August, September, were really about getting information, basic information out about Ebola. And then here's just a list of the variety of info sessions and community forums we've done since August. And so we had the basic ones in August and September. Some of them, there would be prayer sessions at large churches that served, Liberian, other West African communities. So we would go and share information before the prayer session would start. So working with the Liberian Ministers Association based here, which has about 50 Liberian pastors and work in 30 different churches. Also memorials, and then the messaging really shifted. By November 8th, we had a session focusing on stigma related to Ebola. And so we had some federal partners come and work with us, the Department of Justice, EEOC, and then the Attorney's Office, and we all worked together to make sure that people understood what quarantine, what monitoring was, what isolation was, when Minnesota would have to utilize quarantine or isolation, and why, and how we would want to work with the community on that. So just here's some examples of our toolkit, and so the fact sheet was, very static. We created it, using what was out there, but the frequently asked questions we continually adapt based on community feedback. So we're always updating that on the website, and also when CDC does Twitter days on Ebola, we pay attention to those questions as well. When the first case occurred in Texas, we had a lot of the leaders reaching out to us because many media, mainstream media, national media, were reaching out for interviews with some of those key leaders, and they really wanted to make sure that what they said was in line with our messaging and that we were all on the same page. So they reached out to us immediately as they were getting calls from New York Times and other media in really asking for assistance and direction on some of the talking points and some of the things that are occurring here in Minnesota. We often use that CDC Ebola infographic. We really like the use of plain language, simple messages with images are just so beneficial. We ended up creating an infographic on how Minnesota would handle a case of Ebola, and that one got extensive play on social media through our West African community members. And utilizing some of these new partners that we've engaged during this Ebola crisis has really proven to be beneficial now for future ongoing health issues. So we're working, here's an example of the Facebook page of TMZ Radio Africa, which they broadcast here and in Liberia. So they have on their website, they're sharing our flu information, and we actually had them create some PSAs. So we thought we would just play a little bit of that PSA for you to get an idea of that.
Now is a great time to get your flu vaccine. Protecting yourself from flu also protects the people around you who are more vulnerable to serious flu illness. Everyone 6 months of age and older should get a flu vaccine every year. The flu vaccine is available by shot or nasal spray. Your doctor or clinic can tell you what type of flu vaccine you or your family should get. This message is a public service announcement from the Minnesota Department of Health, brought to you to the kind courtesy of Radio Africa.
Great, so that's just an example of utilizing some of the things we've built up in the relationships we've developed during this Ebola crisis for future issues and current just seasonal flu, travel. So we've done a campaign about travel, getting vaccinated first, consulting with your doctor. And so we really just want to make sure to always have those, like the gentleman from CDC said, not just in a crisis, but utilizing them in non-crisis situations like our seasonal campaigns on flu, travel, and so on. So lastly, just a few strategies and key takeaways are, our credibility as an institution is just key.
And then fears and myths can definitely override common sense, as you may have noticed in your states.
We've definitely seen that faith leaders must be involved, especially with the communities we're discussing that were affected by Ebola. We found very, very strongly religious communities there.
And relationships must be developed and maintained before a crisis hits.
And what we really saw helped was empowering the community to be valued partners. When the African Against Ebola Task Force were formed and as they've continued to exist and work with us, they're always an equal member at the table. We really value their input. They have quite a few dynamic key leaders in there, but knowing that they feel like they have power in the situation too, and it's a community engagement rather than just a one-way outreach, has been very, very beneficial.
And lastly, just our partnerships between many stakeholders, local public health, state, community, and faith-based groups are really essential to our success and everyone's success, and also avoids duplicating efforts. So that's all we have.
And yep, we'll take questions at the end, but feel free to contact us individually as well if you have any further questions after the webinar.
Thank you so much. We look forward to learning from other states.
Thank you.
Great, thank you both. Really appreciate those insights. Next we have from Rhode Island, Anna Novaes. So if you are ready, Anna, I will let you take over. Or let me know when you want me to advance your slides.
So now I'm ready.
Okay,
Afternoon,
great.
everyone. My name is Anna Novaes, and I am an executive director here at the Health Department. The division that I oversee is the Division of Community, Family Health, and Equity. And the reason I'm bringing that up is because as a division and as a department, we have a long history of very strong relationships with the minority community in our state, the racial and ethnic minority community, with faith-based organizations, with community-based organizations. The Office of Minority Health, the Refugee Health Program, they are housed by this division. And we've had also a very long history and strong partnership with our Center for Emergency Preparedness and Response. And so when Ebola not happened here, because it never happened really, but when we started these whole conversations around Ebola, what to do, what not to do, our division and our office was in a key position to support those efforts. So I call the Ebola response in Rhode Island, we call it, this really came from our director, calm, thoughtful, and vigilant, and we always started all of our presentations with the community with those words, because as the previous presenters were talking about fear and stigma and unknowns, or what people didn't know at the beginning of this event was really playing a key role more than real science and policy decisions. So the picture that you have, in fact, at the beginning, you can see, you don't know that, but there's Dr. Fine is our director, myself, the Angie Ancoma, who is the chief for the Office of Minority Health, and then 3 community leaders. And I point that out because that was the beginning of our response and when we started the conversation with our West African community. So what makes us unique, as you all know, we are a very small state, but what makes us unique is the fact that we don't have local health departments. And so we are the ones, as a health department, building the relationships not only with other state agencies, but also with our community partners. Also, what makes us very unique is while we are very small, we have one of the largest Liberian populations per capita in the U.S. And that makes the need to address what's happening, the concerns, the issues, the anxiety within the community during this event even more key to our successful response. So we started having collaborations with the West African community early in the summer. We had a group that came to us from the youthful community. They called for a rally at the Statehouse, in fact, just to raise awareness at the community. And they reached out to us through our Office of Minority Health. So we went and we participated. So that collaboration from that one first-time meeting with the youth, it was a youth-driven event, started what continues to be a weekly engagement with the West African community. And it was important for us at 2 levels. One, because we felt that the community will be able to inform health of what was happening at the community level, but they would be also able to rely good information to family and friends in West Africa, and helping address what was in West Africa was important. We also established a very strong collaboration with West African elders. And that was important to us because, as we all know, traditionally elders are seen as the voice of wisdom and knowledge. They are respected as trusted sources of information, and to be able to stand side by side with the elders of the West African community here in Rhode Island and have them not only be our messenger, but also validate what we were trying to bring over to the community and help navigate and bridge was a very important thing, and was very successful in what we did. I stress the collaboration with the West African youth because, on a sense, they were the entry point. They were the ones who had a call to action, as I referred before, into what was happening. They are a very motivated group in Rhode Island, and they're also serving as a bridge to their parent generation. So we had we built those two bridges, one from the elders and one from the youth, trying to reach also the adult population. And one of the things that we want to continue to have in mind is how to channel that engagement so they can continue to serve as ambassadors moving forward, even outside of a crisis situation. So this is a picture of their statewide Statehouse Rally that was at the beginning of August, and this is at the State House, in front of the State House, where all youth came together, and they were really calling for attention of what was happening in West Africa. From that, one of the things that we created that I wanted to share with you all was what we call our Call 5 campaign. So folks were telling us how when they talked with family and friends in West Africa, folks were not trusting the information that they were receiving, and there was a need to really have information get to the hands of the population. We heard from the first presenter how important it is to stop the epidemic at its source in West Africa. So we always engage with the community with those two perspectives, how to support what was happening back home and how to support our efforts and be better prepared here in Rhode Island. So the Call 5 campaign was a collaboration between United Way in Rhode Island and Cox Communication and the Liberian community. And between Cox and that is the communication agency, and United Way, we were able to have community members trained and supported with very specific messages that we developed, and you can see the flyers that the flyer that was part of the Call 5 campaign. Call for free, at no cost to them, their family and friends in West Africa to share accurate information about Ebola. And we call it the Call 5 campaign because every person was asked to reach out to 5 people, and then those 5 people that they reach out would be able to reach out to another 5 and so forth. We also were very engaged with church and other community meetings, and we've participated at any and all events that we were asked to participate. As we know, this is a very religious community, and so the partnership with the faith-based and service communities, being able to rely on their leadership and be the messenger and be the invited guest at their homes, at their churches, and sharing the information through those mechanisms were also a very successful event. And we had our Call 5 campaign. We use a United Way van, parked in fact at some Sundays in front, outside of the churches, so as people came out of service, they could do the Call 5 at home. So we mixed those two together. We also used the professional associations to help with flyer distribution. The picture you have in front of you is from our Liberian, the leadership of our Liberian Nurses Association. They were at the table with us. And so as we develop information with their guidance and folks from our communication center, we printed those flyers and we distributed to them. And they used those flyers for their own purpose and their own education and outreach events, not only here, but we also found out that they send some of those flyers back home, in fact, as a good source of information. We supported supplies drive. That was one of the initiatives that the youth did at the beginning, and so they had asked for our support initially to just collect supplies and be able to send those out. So we did share their information, their list of needed supplies with our network. But then it was really working with them to help them move from collecting supplies to more of a organized fundraising to their folks back home, and through the nonprofit or NGOs working in the West African 3 affected countries. In our state, as you can see, even I hope you recognize, but that's our governor in traditional attire, and that was a candlelight vigil, another event that was created by our youth, and that brought all of the community together. Trying to, on this one, was not only honoring the lives that were lost in West Africa, in the affected countries in West Africa. But it was another moment of reflection, bringing the community together and recognizing and honoring those who served. So the second picture, in fact, is from the journalist from Rhode Island that got sick when working, got sick with Ebola and was treated successfully. So he was recognized by the community and honored as a way to support addressing the stigma and associated with Ebola. So that was another good moment. And also at the Candlelight, we had the opportunity to once again engage with the older members and the other faith-based organizations in Rhode Island. So really bringing together, creating that common community, the one people, as we used to say, one community. So it was by having a diverse participation. It was not only about the West African community, but about all of us, Rhode Island community, coming together to address Ebola. And that was, in fact, one of the things that, as we did the response, being able to navigate the need to address the West African affected countries and community in our state without creating stigma and without separating them from the community at large, and really being one single response in our messaging. So, I don't know what happened. Okay, where'd it go? So in summary, and I hope I didn't spoke too fast, our collaboration with the involved community has allowed health staff, community members, and family members to not only learn together how to stop the outbreak in West Africa, but also how to prevent the spread of Ebola in Rhode Island. The relationships that we develop will be very useful moving forward, addressing other areas of disease prevention and control, such as the flu, but also other ongoing programmatic areas, such as refugee health and minority health. But it's only possible because those relationships that were developed right now came because we had already a history and a very strong reach within the community that was affected. Examples of things that we're doing, as I talk about the flu campaign, we are having flu clinics at our Ebola community events. We now that we've been meeting on a weekly basis, as I said, with the leadership of the West African community, and so we are trying to use that as an advisory group to also check in some of our assumptions and asking for advice around other areas and not just specifically Ebola response, but refugee health and minority health. And so we are continue to engage with them on a weekly basis, not just through meetings, but they are part of our key partners, Ebola updates. So we send those out on a weekly basis. That's through email. And we have a commitment to continue to have them work together with us as we move out of this response, but to more programmatic, ongoing public health work. So it's been a challenging time in our state, but I also think it's been a very rewarding and learning experience by having this commitment to work with the West African community in Rhode Island. I will be able to answer any other questions after, but that's what I wanted to share for now. Thank you.
Terrific. Thank you so much, Anna. We really appreciate hearing from Rhode Island about some of the great work you guys have been doing with your diverse communities. Next up, I have Nikki Beneke. She is from Dallas, and as you can see here, she has a number of hats that she wears, but was very engaged in the response to the first Ebola cases identified in the United States in the Dallas area. And so, Nikki, I think we're all very excited to hear some of your reflections on that experience and the important role of the organizations that you represent, as well as other community organizations and the engagement with them during the response. So, Nikki, if you're ready.
Thank you, Connie. I have to say that I'm surprised I haven't heard VOAD yet in the call, so I'm glad to know that because I thought I was going to be repeating something at the very end. When we first had Mr. Duncan diagnosed, we actually had no preparation for Ebola because we never expected to have Ebola. And so we certainly locally, I got calls from organizations asking me if I had any information on protocols for volunteers, because many of our volunteers worked in the same area that Mr. Duncan lived in, which was Vickery Meadows. And they wanted to continue their work, and their organizations wanted them to feel comfortable continuing their work. So I called our health department, our county health department. They were actually very, very busy with getting enough PPEs together, making sure that they had everybody trained, starting their monitoring. They were ramping up their monitoring of the people who had any kind of connection to this. So they suggested I called the CDC, which I did, and I have a person from the CDC who is on the National VOAD Communications Committee, and she was very helpful, and she referred me to some of the website information. We pulled that together, but there was really nothing related to volunteers that was just specifically for volunteers. And so we did put together protocols locally, but also CDC started to work on some. So there's a very nice handout. So if you haven't seen that, you might check on that. It's a very nice handout for volunteers, for your organizations, your churches, any of the people you're meeting with. And I know some of it's been translated into different languages here, I'm sure, because we translated a lot of things this time. So once we got the protocols in place and we were able to give those out to some of our organizations, then what we realized is we needed to get the information out through the VOAD listserv, but also to other organizations like universities, schools, nonprofits, foundations. And we did do that through just our own dissemination of information. But when we did that, we also asked them to, if they had people who could translate any of the information, to do so. Well, a lot of the information was translated by our schools, our universities, and some of them are on websites, and I can give you all links to those if anybody's interested. The VOAD was asked to disseminate information to the community. The health departments and the schools are the ones who did the translations. We did not do that. And but I think that the awareness and the resources for messaging, it increased greatly during that time period because we were aware of more and more information as it came forward. When the second and third patients were diagnosed, the VOAD and the county ramped up their messaging, and the county actually called us and asked us if we could do some door-to-door campaigns. So our volunteers actually went door-to-door in a lot of the neighborhoods, a lot of the areas, and took things that were translated, took things that were in English, whatever we needed. We also encouraged our VOAD organizations to carry messaging with them for any opportunity they might have to share information. We used social media to improve the quality and the accuracy of information because what we noticed was the information was very, very inaccurate in a lot of cases. If anybody was on Facebook at that time, they saw a lot of inaccurate information. And certainly if you were in Texas, you saw a lot of it. So we were able to catch some of that and really put out the right information. We had some VOAD organizations who set up and took calls from the public, as did the county, as did our 211. So they were able to answer questions as it came up. And this really kept some of the real fear down that we saw originally start when the second and third patients were diagnosed, and those were both nurses. The health department is already involved in the VOAD. We work with them directly. We have Medical Reserve Corps within our VOAD also, and we have a long-standing relationship, more than 40 years, with all of our faith-based and community partners within the voluntary organizations active in disaster in Dallas County. We're one of the oldest VOADs in the country. And so we do know our resources. We know who has what and who can get something on short notice if we need it. So when the VOAD was activated to assist the quarantined families with needs, we followed our disaster protocols, and with one point of contact for the VOAD, we were able to deduplicate the requests because what we noticed is we were getting requests from a lot of different organizations, and sometimes they were the same request. And so we were able to deduplicate that. Early in the Ebola response, one of our families, as you know, needed to be relocated to decontaminate their apartment. Because of their new location, they required a great number of supplies to actually set up a home. They had some basic furniture, and that was it in this home that they were put into. And it was in a gated community, so they were protected from the media issues that they'd had previously. And so we provided everything they requested, whether it was kitchen items, linens, furniture, clothing, games, other activities, computers. one of the things that they did request was specific food and clothing that were culturally oriented, and we were able to get those requests fulfilled. We work closely with the emergency managers, the county, the local EMs, and the health department. And not only the health department at the state level, but also the health department at the county level. And in the state of Texas, we are a home rule state, so our county judge is in charge of the response at that point. And so even though that is true, I saw the county and the state and the city all work together very collaboratively along with the CDC, and it was an incredible experience to watch everyone work together. But we were able to make sure that whatever was requested, whether it came from the epidemiologist or the emergency manager or the health department, that those needs were provided for. Our health department went out to meet with the families who are quarantined or the families who are monitored from time to time. The family who was quarantined, they actually met with them quite often. The families who were monitored were then affected also by a power outage during that time. So you always have to be prepared for the next thing that happens, which we had a storm that knocked out a lot of power in Dallas. And we were able to provide the families who were being monitored who would not normally be taken care of, we were able to provide them with lanterns and baby supplies. And we picked up and delivered hot meals, although they didn't request them. But I think all VOAD organizations are used to feeding people during any disaster. And but it worked really quickly, and we were able to take care of the families as the needs arise. We got really good information from the county, the city, the health department, on the state and the local level, and the CDC as to what needs there were and what needs existed. We coordinated calls. There were coordination calls held by the county, and they included the state medical director, the county OEM, the county health department, the state health department, the VOAD, the CDC, the mayor's office. It was everybody was on the call so that we all knew exactly what needed to be done, and we all could work together and coordinate with what was needed. Some of the things that we noticed during the time that I do want to share with you is one of the problems we had initially was just deduplicating some of the requests that came through all of the different organizations, and we were able to work through that to where it came through one point of contact to us, and we were able to fulfill it within that day each time. Seasonal influenza messaging is very important, and we've talked about this just recently, and the VOAD is ready here to communicate any kind of information that we have, not only to our organizations but general public, and coordinate with the county and the state health department to do so. We spent a lot of time educating people about hand washing, infection control procedures, and many of our staff and volunteers have commented that they have enhanced awareness of how important it is to take care of how they wash their hands, what they're doing just in general infection control type of activities, just because we're running into flu season. And they said that they've never really had that awareness before as strongly as it is this year, and I think that that's partly the Ebola that we just went through. And there is, of course, a difference, and they know the difference, and we've given them information on that. Some of our suggested strategies would be to meet and participate certainly the health departments to meet and participate in the VOADs, the volunteer organizations active in disaster at the local and state level, and get to know your VOAD and become a member, because I think that way when you have a need, you can just pick up the phone and say, we need something, can you provide it? Most of our organizations are community-based and faith-based organizations. They're some of the ones that you'll hear on the national level also, and they're always willing to assist in any way they can. We also, one of the things that we really felt strongly about was we need to have the messaging ready in languages that are needed in our communities, and a plan for distribution of that information is really, really important. Messaging and communicating was really something that came up every time we discussed this afterwards in the after-action review. There's always a best way to dispel any myths is through messaging communication. It generally calms the public, informs the public, and it gives them that empowerment of knowing what's going on. And For any of you who don't know what voluntary organizations active in disasters are, our key message is the 4 C's, which is communication, coordination, cooperation, collaboration. And those are things that I saw worked very, very well here locally when we were working with the Ebola response here. And that's all I have, unless there's some questions at the end.
Thank you so much, Nikki. So I think that it's a great time to go ahead and open it up for some questions and discussion. I'm going to take the convener's prerogative and ask the first question, and then I'd like to open it up to the audience as well as to our presenters. In a moment, I'll go ahead and unmute all the lines, so if people, if you're not going to be speaking or asking a question, and again, I'd like to remind you that this is being recorded, so if you have a concern there, you may not want to raise the question by audio, but you can certainly submit it in writing through the chat section of the web portal. So the first question I'd like to ask of the states, as well as Scott, if you have any sort of reflections on this, could you talk a little bit about how you might have been able to address any sorts of concerns within your agencies related to separation of church and state? This is something that we've heard from a number of folks about the ability to engage, or the perception that that state health agencies might be able to engage with faith-based organizations on any sort of health topic, public health issue, because there is this phenomenon we call separation of church and state. So I would open it up to our presenters to see if they have any sort of reflections on that.
So this is Anna from Rhode Island. I guess because we have a long-standing relationship with the faith-based organizations through the Office of Minority Health and our programs here at the health department, and because we don't have local health departments, and so we have no choice but engaging ourselves, that did not show up as a concern, in fact.
Hi, this is Danushka and Sarah here in Minnesota. When we were working with the faith-based community, we definitely did have to reiterate our scope, in the first couple meetings, and then whenever we were invited to a prayer session, we would just ask to share that we would share the Ebola information before the prayer session would get started, or they would make sure we would be at the front of the agenda. When it came closer to like fundraising, we definitely let them know early on that whenever they wanted information and material, we would be happy to provide it. But if an event was very focused on fundraising and religious nature, that either we would come at the beginning and share something, or that may not be the best venue for us, but we would provide printed materials for them.
Excellent. Scott,
Hi.
I would be curious if you have any sort of reflections on that question.
Yes, hi, this is Scott, and I'll just mention a couple things here. And I think that those are really valid concerns about the fact that we as government employees have to respect those appropriate ethical boundaries. And I think that so when people raise those concerns, we should recognize that that's really a valid question. However, we've shown that it is possible to work with faith-based groups and community groups and respect the appropriate boundaries and still be able to work together toward common goals. If you look at where this has been looked at by the Supreme Court in the past, when there are partnerships between government and religious groups in particular, the important things to remember is that the effort has to have, in this case, a public health focus, primarily a public health focus. So it would be focusing on something like influenza or Ebola, something of that nature. The role of the government is not to advance or inhibit religion. So we really don't get involved with that part. We focus on the public health part, as my colleague said. And thirdly, we shouldn't, the effort shouldn't lead to any kind of entanglement, unnecessary entanglement between government and religion. And I think that we can work together and keep the two separate, but work together as partners. So there are ways to do that and still be able to collaborate with these groups. One last thing I wanted to mention was it is important, it's valuable to be able to work through the VOAD networks that Nikki mentioned. And when you work through a VOAD network, that's actually working with many different religious groups and secular nonprofit groups. So that's really useful for government entities to know about the VOAD as a partner. For example, some of the prominent VOAD partners include groups like the American Red Cross, the Salvation Army, Catholic Charities. There are groups like the United Way, and there are a number of different diverse religious organizations of many different faiths represented on the VOAD. So wanted to make sure that people understand that about the VOAD network.
And if I could just add, this is Anna, another thing that we have here in Rhode Island, and I think it comes from this long standing relationship, we also have the interfaith leagues, and so we rely a lot on these groups that come together as interfaith groups. So not to have, they continue to be faith-based focus, but they are not of a specific denomination. And that has also helped build the bridge and clarify what we do. We also use the tactic, the strategy of either coming at the beginning, being clear at the agenda as this is what we're going to be talking about, or coming at the end of the event.
And can
I think those are,
Connie,
oh, go ahead.
Can I say, thank you, Scott, because I was going to say, with a VOAD, certainly it works more like some of the interfaith groups do because we all come together. There is very little issue with what you're talking about with the separation of church and state. We work a lot with FEMA, as you know, and we work a lot with the emergency management community, and we work a lot with all the different government communities, so, government agencies. So truly, there's not that type of an issue. And as a member of the VOAD, I think there's even less of that type of an issue when you're talking about that. And I do know that some of our emergency managers have participated in some groups, not necessarily VOAD groups, but some faith-based groups where they've gone in to talk to them, and they do go at the beginning of the meeting because I've been there, so I do know that.
Great, thank you. And for Nikki, I have a sort of a specific question for you, and then I have to open it up to the other speakers to see if they've had any sort of experience with this. We have a number of state health agency folks on the line who are not specifically engaged in emergency preparedness within the state health department. A number of folks on the line are, but a number are not. So, for example, we have folks from infectious disease and immunization programs. We might have some folks from surveillance and epi programs, refugee and minority health programs. And I was wondering if you have any suggestions or insights about how those programs might better engage with VOADs across the country, and what sorts of offerings might a VOAD have in a particular jurisdiction for, say, refugee or minority health programs or infectious disease immunization programs, if you have any thoughts on that.
Well, it's interesting because I don't know if you know this or not, but we had certainly, I'm with St. Vincent de Paul, Society of St. Vincent de Paul, USA. So, we as a group, work a lot with the vulnerable populations, and we work a lot with the refugee populations, just like Catholic Charities does. But during, prior to the Ebola, this summer we had, of course, the situation with the children who were coming across the border. And we were working at that point with not only the emergency management group, but we were also working with some of the health department people. So there are a lot of opportunities to work collaboratively, I think. It just depends on, I would say just invite yourself to a VOAD meeting. Invite yourself to meet the people. I think that will give you a feel for who they are, what they do, and we're always open to having people come visit. A lot of times I have people come in and speak from different groups, certainly from the health department, and it's not necessarily emergency management or preparedness at all times. However, I think that it's very valuable to us to hear more from people who speak in the area of infectious disease, because that was something we were not as prepared for. I was more so because of my background in medicine and because of the fact that I did the pandemic flu preparations, but there are a lot of people who weren't. And so I think that anything we can do collaboratively like that is going to strengthen our responses as we go forward, and certainly strengthen the VOAD and strengthen the health department and their relationships. We certainly have groups that are, disaster oriented within our VOADs. This was a non-traditional response, not only the children coming across the border from Mexico, but also the response that we just did of the Ebola. That's a very non-traditional response according to people around the country. But what they don't know is Texas, we have a lot of non-traditional responses, so we just do them. I think it's just an opportunity to meet and really understand better what we all do, and I do think there's opportunity for collaboration regardless of what your specialization is. I think that there's always that opportunity to learn more about what we do and how we can be of benefit. And I do think they should just invite themselves to some VOAD meetings because VOADers are really open to that. And the more that they get to know them, the better I think everybody will be.
Great, thank you. So for any of the other speakers, do you have any experience working with VOADs in your jurisdiction that you'd want to share?
So this is Anna. Here in Rhode Island, we've worked with them both through emergency preparedness of outside. So the United Way, as you know, it's one of those organizations. But through emergency preparedness, our Center for Emergency Preparedness and Response has worked very closely with all of the VOLAGs in our state, making sure that they are engaged from the get-go. And I think that's how we were able to, for example, do the Call 5 campaign. Outside of that, outside of the specific response, one of the things we've tried to do in order to engage and have other folks be understanding of emergency preparedness here in our state, it's having what we call a low threshold for trying to create mini ICSs as a training for our state to respond to events. And so we've done that as a way to engage the health department in emergency preparedness and our partners. We also have asked and worked very hard with all of our staff to get them trained. And so people are aware of emergency preparedness. And when we have events, we engage different folks and we bring them on into our response, and we rotate folks through that process. So we keep folks aware of how things work, and we use their relationships and their partnerships into our response, and then that can bridge outside of the response.
Thank you. Others?
Here in Minnesota.
Oh, go ahead.
Yeah, I was just going to say that here in Minnesota, our Office of Emergency Preparedness as well works most closely with the VOADs, and in this situation with responding to Ebola, we did not actively seek out VOADs, but Danushka brought up a good point.
We did work with the cultural service units, which were created by Hennepin County in the metro area to bring more diverse folks into emergency preparedness, health and safety, and so it's seen as kind of a feeder for the Minnesota VOAD. And they're all enrolled in Minnesota Medical Reserve Corps and so on. And so that we definitely recognize the importance and can't stress enough how valuable it has been. One of the cultural services units we worked with from Brooklyn Center, I think about 70% of them were actually West African. This was created 2 years ago. And so that group was just instrumental in getting information out. There were a couple faith leaders in that group, and so we definitely value that.
Great, thanks. I think what I'm going to do at this point is go ahead and unmute the lines, and then I would welcome any sort of thoughts that other folks who are participating in the webinar, if you have had experience working with VOADs in your community, if you have any sort of recommendations or suggestions of what facilitated that engagement and those partnerships, and how you might see that being helpful in terms of pandemic preparedness, but also seasonal flu. And then I'll also welcome any questions from the line.
The conference has been unmuted.
So great. The line is open. If anybody has a question, I welcome that. While folks are maybe sort of formulating their thoughts, we did have a question come in through the chat section that referenced a specific government document, the U.S. Army Medical Research Institute of Infectious Diseases report, I think, the 7th edition of that released in 2011. And the question basically is there's some seemingly conflicting information in that document versus some of the things that we have heard. And to the idea of communication, to the broader subject of communication rather than the specific content of this report, the question is basically how do state health agencies and local health agencies communicate with their communities when there seems to be discrepancies between different government-produced documents, and that might be federal government versus state, and how are there any sort of suggestions for what maybe Scott, if you have some reflections on how you from the federal government perspective sort of see that issue, and then from anybody else on the line, if you've had some experience in terms of communicating seemingly disparate information to communities and sort of clarifying any sort of confusion that might emerge from people having exposure to different documents or different sources.
So this is Scott, and I'm not sure specifically which document is being referred to, but I know that sometimes there are differences of opinion among scientists in different federal agencies and in academia and so forth, and it's good to have those debates because they keep us kind of on the cutting edge of science. It can be confusing to the public when they hear different opinions or things being debated back and forth, though. And so I think it's important for communication folks and for our community partners to be able to focus on the many things that we do agree upon. There are, step back and look at the big picture and focus on those things that, we're all interested in protecting people's health. There are certain key things that are not debated between scientists, and really focus on those areas and make sure we get those messages out, because there are the vast majority of things I think we do agree on.
And I did find the actual citation. Forgive me, it was the Medical Management of Biological Casualties Handbook. Whew, does not roll off the tongue. But anyway, that was produced by the U.S. Army Medical Research Institute of Infectious Diseases. And there was some specific sort of commentary, description of transmission of Ebola in that document. So the question was raised, how do you communicate those differences of opinion? So anyone else want to respond to that?
So this is Anna. One of the things that we've dealt with in Rhode Island, less than conflicting information, was more of information coming at different times or with different approaches depending on the organizations. And one example was PPE. Well, there were specific recommendations for different groups, but everyone is asking at the same time. So what's needed and is important for EMS, it's different from healthcare providers. And at the community level also, as the situation changed and as we learn more, that's not that it was conflicting, but it was like new knowledge. So one of the things that we kept saying that I believe helped was, this is the information that we know today based on the current knowledge, and it may change. So kind of setting up the expectation for something else coming up, but setting it up on a sense that this is what we know today. And the other thing that we tried to do was going back to the basics all the time of those facts that we knew were really very not changing, like how Ebola transmits, for example, and all of the 21 days, the non-transmission if no symptoms. So going back to those basics also, and on the other ones, this is what we know best answer based on the science today.
And this is Scott. I'll just add to that. So I think perhaps this question relates to the debate about whether Ebola could be spread by a respiratory route, because the message we've been repeating is that someone has to be in contact with bodily fluids to get infected. And so I would just, we look at several different pieces of data, pieces of information to support our statement that it's really spread through bodily fluids. If we look at the spread of the epidemic in Africa, it looks very much like it's spread through direct contact with bodily fluids. If it were spread through the air, it would have a very different epidemiologic focus. It would appear very different than it does. So that supports that it is a spread through bodily fluids. Secondly, our experience in Dallas, if you just look at the people who were infected from the gentleman from Liberia there, the family and close contacts who were living with him were monitored for a 21-day period, and none of them became infected. If it had been spread through the air, they might have potentially gotten infected, but none of them did. And the two people who did get infected were the people who were caring for him when he was very sick, when he was producing a great deal of bodily fluids. And so that, again, supports this statement. Thirdly, genetically, the way that we've looked at the virus, it doesn't appear to be one that would mutate to respiratory transmission. That's always possible. We always watch for that kind of thing, but it doesn't seem to be genetically along that tree of the type of virus that would change from one that's spread by contact with bodily fluids to one that's spread through respiratory transmission. So that's kind of our thinking along those lines. We should be, transparent about what we know and what we don't know here, but we continue to support the thought that it's spread through contact with bodily fluids.
Thanks.
This is Danushka here from Minnesota. A couple things to add with regards to that question. First, we would always start with looking to CDC for information and really trying to stay in line with them, and then working with partners to continue that consistency. Number two, we have a Metro Public Information Officers Group, PIO group, and so our executive office here at the Department of Health would convene this group monthly to make sure that the PIOs from all the various counties and community health boards would be all on the same page. We talk about messaging, we talk about the newest materials available, what we recommend, and so forth. We also would try to make sure to have a concerted effort between partners when there was misinformation out there. And lastly, I started emailing, probably 4 or 5 key leaders in the West African community. I had mentioned those weekly emails. Well, more and more people were added, and soon, other county folks, local public health asked to be added to the list, just so they could see what community members were receiving, what information they were receiving, so that to maintain consistency there as well.
Thanks. So I'd open it up to our presenters or anyone on the line at this point for questions. Fortunately, I had one question submitted in advance, so I will throw that out here. So one challenge that a jurisdiction had experienced in terms of working specifically with their West African community has sort of been the dynamics of relationships within the community itself. And the question here is, have other states experienced this in terms of in relation to Ebola or any sort of other public health issue? Have you experienced this? And if so, what advice do you have for overcoming some of those challenges of intercommunity or intra-community relationships?
This is Danushka here in Minnesota. And, there's definitely some politics that go on between some of the groups we were working with. That's why we were so appreciative of that umbrella task force that a lot of the community leaders came together to work on, so that they could combine their efforts on those shared goals, because many of them did have, a variety of other initiatives and work that they do for preventative health, for civic engagement, all types of efforts. And even initially, in our first meeting, we had to be clear in that we wanted to, our info sessions, everything we wanted to do, we wanted to be open to the entire community, not just Liberian, but also other West African countries, and not just West African, but also other Minnesota residents, and so on. And so, I think that was some discussion early on that we went through that we didn't have to revisit as much later.
Thanks.
This is Scott. And I would just, to address that question of inter-community relationships, that there are sometimes politics and issues between different groups and that kind of thing. And so my advice to the public health folks would be to work with these different groups over time, develop the relationships and maintain the relationships over time. And you develop trust with those groups that can be reliable. If you work with them around many different health initiatives, everything from flu shots to other health initiatives, you begin to understand how the different components work together and that kind of thing. And so those relational dynamics, and that's much better than just trying to throw something together right in the middle of an emergency when you don't know any of the partners and how the groups relate to one another.
Good point. So any other questions from the panel or from the line, from those folks on the line? Hearing none, I guess I will wrap up just a couple minutes early, but I want to thank, first of all of our speakers for your thoughts and the hard work that you do, and then also to thank all of the participants on the webinar because you guys are working hard too, and I hope that you found this a useful opportunity.
It sounds like we've lost Connie.
Yeah, we cannot hear her anymore.
Well, at this point, she just has the final slide posted that says the webinar will be archived, email any questions or future topics, and reminding people about the RFA.
Great, thank you. Signing off from Minnesota.
Thanks, Scott.
Thanks, everyone.
Everybody for coming.
Thank you.
Thank you, everyone. This is Anna signing out.
Thank you.